Hey, good afternoon, everyone. Thank you so much for joining us for today's webinar, Mosaic Approaches to ADHD and Stimulant Use Disorder. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenters. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME and McBAP credits for today's webinar. We will have a slide up with information about obtaining these credits during the Q&A portion of the webinar, and we will also email the continuing education credit information after the webinar today. My name is Melissa DeMars. I'm a behavioral health specialist with the Overdose Prevention Engagement Network, and will be moderating the webinar today. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery, with an overarching goal of developing transformative, evidence-based solutions to reduce harm and stigma surrounding substance use. We work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain, and they can answer both individual treatment and technical assistance questions. We also offer expert-led education and training sessions. All of our webinars offer free CME credits, and many of our webinars offer CEU and McBAP credits. And for prescribers, all our credits also qualify for the DEA-required substance use disorder training. We provide medication for opioid use disorder training for physicians, and this year we're incentivizing primary care providers with $250 to complete one of our MOUD trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide data to inform opioid prescribing. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable educational materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. We provide overdose rescue support. We also fund implementation of naloxone vending machine and distribution boxes, and we provide naloxone administration training. These trainings are offered as live, virtual, or free online training courses. You can access more information about all of these services more directly using the QR codes or visiting our website. No planners, faculty, and others in control of content, either individually or as a group, have any relevant financial relationships with ineligible companies. And with that, I'm pleased to introduce our speaker for today. Dr. Vida McCabe graduated from University of Chicago Medical School in 1997 and trained in cardiothoracic surgery at the University of Minnesota. She has lived in Ann Arbor since 2003. Through her own health problems, she retired her surgical career in 2015. In transitioning her career, she completed a master's degree in health management and policy from the University of Michigan. She served as the chair for LARA's Health Provider Assistance Committee, which oversees policy, statistics, and two-step review for the Michigan Health Professionals Recovery Program for all of the health professional boards. Dr. McCabe served as first Chief Wellness Officer for Trinity, Michigan, After pursuing these roles, she became board certified in addiction medicine in October 2020. She felt strongly that a psychiatry residency was paramount to be of most service to getting healthcare healthy from the inside out. And with that, I'm happy to hand it over to you, Dr. McCabe.
Thanks. Hi, everyone. I'm Vida McCabe. I am an addiction psychiatrist and addiction medicine doc at the U. I'm hoping you can see my slides well. So last time
Yes.
perfect, thanks, had a talk, it was a little bit of a disaster, so I'm a little gun shy. In terms of disclosures, our team we get funding from NIDA and the FDA. Also married to one of the co-investigators and PIs, Sean, and we got a couple of kids. Our learning objectives today are a review of ADHD evaluations and diagnostic criteria. We're going to discuss some characteristics as well as methods to reduce stimulant misuse, look at some trajectories of substance use disorders in individuals with ADHD, take a quick look at diversion sources and how COVID changed it in adolescents and young adults, as a reminder that the landscape's always changing. It's a talk about ADHD given in an ADHD way, so we're going to have lots of stuff coming at us from lots of directions, so hang on for the ride. So ADHD is diagnosed through symptoms falling into two categories. The big categories are inattention. The other category is impulsivity and hyperactivity. If we're looking at adult residual ADHD, which is really more my clinical focus, you have to have 5 or more symptoms per category, longer than 6 months duration. You have to understand that the disease started, or disorder, started before the age of 12 because it is a developmental disease, and it has to be impairing in 2 or more categories, can't be accounted for by another disease. So that is the basic DSM diagnosis. There's 3 categories of ADHD. It's all ADHD now. There's no more ADD. So it's inattentive, hyperactive, or combined. If we look at worldwide prevalence, right, in about 8 to 15-year-olds, it's about 6 to 9%. In the US, it's a little higher. We kind of classically think of it as 10%. In 18 to 44-year-olds, 4 to 5%. ADHD has a chronic course, so 75% persist into adolescence from childhood, 50% persist into adulthood, high rates of psychiatric comorbidity, but it responds well to treatment. We'll get kind of into the weeds a little bit on that. Risk factors for ADHD are really threefold. So genetic familial risk, and really it's one of the most heritable diseases, as heritable as schizophrenia or a genetically associated breast cancer. So if a parent has ADHD, the chance of a child having ADHD is over 50%. So in assessment, it's always really important to get family history here. There's some perinatal factors, some childhood factors, and I think oftentimes we overlook these, or they're difficult to get the history on. ADHD really changes depending on the age of the person with ADHD. In preschool and severe ADHD, you can see some unintentional injuries, behavioral differences. By college, we might be seeing some academic failure. And in adulthood, it looks a little bit different. Low self-esteem, mood instability, occupational problems, substance use disorders. So in adult ADHD, what we know is fewer symptoms cause greater consequences. There really is an impaired quality of life, reduced ability for employment, driving impairment, disrupted relationships, vulnerability to substance use disorders. And when we look at comorbidities, right, about 87% of adults with residual ADHD will have another mental health disorder. But here's the interesting thing: mortality with ADHD alone, if you compare it to the general population, is 150% increase. But if there are 2 comorbidities present, ADHD and a substance use disorder, or ADHD and generalized anxiety disorder, mortality goes up to about 450% over that of the general population. So diagnosis of ADHD in adulthood, kind of who gets missed, right? So Symptoms of ADHD seem overall to lessen with advancing age. Often, even the impulsive or combined types look more inattentive or disorganized. So, of adults with ADHD, about 90% receive no treatment. Even when adults are treated by mental health professionals for other diagnoses, the ADHD is often unrecognized. So who's it unrecognized in? High IQ or high achievement individuals, women, those who have developed really good compensatory and coping strategies, people in professions that rely less on organization, like sales jobs, those who have a high interest in their job, who really leverage the superpower of hyperfocus from ADHD and kind of the charisma that comes with ADHD. And often those with masking comorbidities like substance use disorder, depression, and anxiety. About 23% of adults with substance use disorders have ADHD. But if you look at that oppositely, about 55% of people with ADHD will develop a substance use disorder. And these are the studies that kind of break it down through the literature. In adults with residual ADHD, male to female ratio is equal. Treatment response in adults is equal to that of kids. Regimens are best when simple and structured, but interestingly, long-term adherence is bad to medications. What about substance use associated with ADHD? Well, what we see is a more severe substance use disorder, typically higher rates of psychiatric comorbidities, less remission from substance use disorder, how the patient defines it, a longer course of the substance use disorder, and lower retention in cigarette and substance use disorder treatment. There are some diagnostic dilemmas, right? We see an overlap of symptoms, both with intoxication and withdrawal. There's reliability issues of retrospective report if somebody is in an active substance use disorder and cognitive impairment. So really, when we're evaluating these patients clinically, obtaining collateral is really helpful, because if you're very strict about DSM criteria, you can't diagnose it if somebody's in an active substance use disorder. I would argue that it's really important to understand whether there's risks and that it's there, because early treatment is also important. Rating scales, standardized ways to look at this are really important as well. And also understanding that patients with ADHD, and especially if you layer on a substance use disorder, depression, or anxiety, they're going to show up to an appointment not having filled out the questionnaires. They may be late. And so offering the support around that to help them is really important. This is just a quick call out to our Canadian colleagues who have published practice guidelines for ADHD that are outstanding and available for free on the internet. Their initial version was published in 2006. And in the US, APSARD, which is the American Professional Society of ADHD and Related Disorders, announced in August of 23 that they're going to prioritize developing US guidelines and specific to adults, but so far that's in the works and nothing yet out in the atmosphere. There are 6 double-blind studies of stimulants to treat current substance use disorder with ADHD. And this would be the gold standard, right? The majority showed no overall improvement in substance use disorder. 1 study trended toward improvement. 2 studies suggest benefit in reducing symptoms with some of the measures, but not others. And 1 study did show improvement in both ADHD and substance use disorder using high-dose, long-acting methylphenidate by Francis Levin in Columbia. So more work to be done there. This is a quick study from Harvard, one of our colleagues who we work with, who did a retrospective cohort study in a single addiction psychiatry practice at Mass General with 203 patients, 171 with ADHD treated, 32 were untreated because they didn't want treatment. And really what their preliminary data showed was that you have better engagement, so more engagement in treatment when you're treating both disorders. So important for future studies. In the context of what do we do in terms of treatment, ASAM came out with the stimulant use disorder guidelines in last year. And really, this tells you what, with certainty and with the references, kind of what we do. And the long and the short of it is really it needs a good evaluation with collateral from family or somebody who has known the person. And then if the patient is engaged, really thinking about using XR or long-acting stimulants, if stimulants are the first choice, or sometimes trying non-stimulants. There was a meta-analysis that just came out recently, and Stratera actually had some pretty good data in adult ADHD. And so a lot of things have to go into this evaluation, but finally we're kind of moving forward. There are no FDA recommended or approved medications for using stimulants to treat a stimulant use disorder outside the context of ADHD. So I think that's also important to recognize. So what do we know about stimulant misuse? So non-medical use of stimulants. Well, I think one thing to recognize, at least in 2022 data, is the lifetime non-medical use of prescription stimulants. It's about 5.3%, and it remains more prevalent than prescription opioids, tranquilizers, and sedatives. So it's a problem, and it remains a problem. About 10% of the general population will report lifetime stimulant misuse, and the peak age is 21. There have been about over 120 studies looking mostly at surveys in college students, about 80% of these 120. And in those studies, it's about a 10 to 20% prevalence rate of non-medical use of stimulants. And within these studies, 65 to 85% of the stimulants were diverted from friends. And really, it's important to note, like, people were not scamming practitioners. They're not dangerous, right? It's really about motivations. So what are the characteristics of those individuals who misuse prescription stimulants is really important, right? So our group took a look at this, looking at motivations using NESDA data, about 102,000 14 to 25-year-olds, and cognitive enhancement increased as the motivator as age went from 14 to 24. So at about 14 years of age, so kind of middle school, early high school, is about 40%. By end of college, it was about a 71% motivator for people. We also took a look at prescription stimulants and school specificity. And what we saw was for at least past year non-medical use, so using outside of the context of a prescription across US secondary schools, is very dependent on zip code. And some schools had a 0% rate, and some schools went as high as a 25% rate. And so it gives us some things to look at within the context of what's going on in those schools. Should we have nurses and school nurses more aware of this, screening, things like that? This was a study also out of MGH that looked at just in people, in college students, if people were using stimulants outside the context of a prescription, lifetime prevalence of any substance use disorder increased to 50%. So pretty high from the baseline. So what do we do, right? Like, how can we as clinicians help give psychoeducation to curtail prescription drug misuse? It's really important. Psychoeducation, psychoeducation, psychoeducation. Did I mention psychoeducation, right? About really kind of what's going on with ADHD, about the consequences of diversion, about the importance of medication, and sending, your kids to college or even high school with a lockbox that they only have access to, and helping them role play a little bit about how you're going to handle it when somebody asks you to use some of your Adderall or your Vyvanse. So and I have a lot of these conversations, and oftentimes when going from high school to college, we'll often try going from Adderall to Vyvanse to use a prodrug to see if it's more safe if the person wants to. We're really careful, especially in this high school, college age, not to overprescribe quantity, and I'll show you why in a little bit based on our research. And then I have links for families designed on safe storage, so they can just click on it to buy it immediately and train their set it up before you go off to college. And then just the confidentiality, right? So, people don't ask you what blood pressure medication's on, how much insulin you're on. This is also really not something that you may want to advertise because you need this medication for your education. All right, so let's look at some trends just overall in lifetime ADHD pharmacotherapy. So this is monitoring the future data. That study is housed at the U of M. It's 12th grade lifetime ADHD pharmacotherapy. And what we saw was an uptick in predominantly stimulant use by the green line during COVID. So it went from about 11% to 14.6% if you're looking at both stimulants and non-stimulants combined. But when you sort it through, it was really the stimulants that were accounting for that uptick, 8 to 11%. And then when we looked at non-stimulant therapy, it was pretty flat. This is IQVIA data published by the DEA. And this only reflects prescribing data and not misuse data. 75% of all stimulant prescriptions between 2012 and 22 were prescribed by psychiatry, which is the top line. It's pretty flat. Then it's the next line down is pediatricians, then family practice. The bottom line shows that prescribing by nurse practitioners has increased more than 5 times since 2012, with currently nurse practitioner colleagues being the highest prescribers. And I want to highlight this because if the DEA is highlighting it, I want to caution everyone on really kind of looking at this data and kind of bringing our NPs in, right? So my concern is that this data is going to get misinterpreted and without a deeper dive. And really what I see here is our NPs are incredibly valuable colleagues, and we're managing this together. And so I don't know, and I suspect some of this shift may have happened in stable patients, and then that shift is happening. But I think in the current climate, it's really important for us to understand what the DEA is putting out and then to manage these interpretations so that our patients can get the care they need by all healthcare professionals. All right, so let's talk a little bit about what happened with COVID and diversion. So pre-COVID, about 57% of non-medical use of stimulants was given to another person for free by a friend. So this is kind of 09, 2011. And what happened is the modal source of diversion in 2021 was not from peers, but now became from one's leftover prescription, which is why really some of the work MOpen has done about having disposal sites, or even sometimes, when I'm worried about a lot of leftover stimulants, knowing this diversion data, I'll have a patient bring in their old prescription if we're changing, or I'll wait till that prescription is out to minimize leftover sources. And here's what happened post-COVID. This is such a busy slide. And really, so now that COVID's off, we still see that leftover prescriptions are the main diversion source. So that may change itself, but more to come on that. This was a paper we put out looking at cohorts of about 12,000, almost 12th graders. And these were surveyed via self-administered questionnaires at baseline, so age 18, and then we followed them prospectively over 6 years into young adulthood. Our main interest was in adolescents' use of non-stimulant and stimulant medications for ADHD, and then later risk of developing cocaine and prescription stimulant use disorders. Really what we found was there is no association with adolescents, so 7th grade and before, use of stimulant therapy for ADHD with non-medical stimulant use during young adulthood compared to population control. So when they use their medications appropriately, they look like population controls. When adolescents use non-stimulant therapy for ADHD, there was also no subsequent development or risk of higher development of a substance use disorder. So no increased risk for treatment of ADHD in kind of 7th grade or before. So then we looked at things from a different perspective and realized that the protective risks depends on when stimulants for ADHD were started, how old were they, and the duration of therapy. So early onset before 7th grade, long duration of stimulants. They look like population controls. There's really decreased use of cocaine or prescription stimulant misuse. Intermediate duration, so 2 to 5 years of stimulant use had kind of intermediate risk levels. And adolescents who started stimulant use in secondary school, so high school, 8th grade and high school, with new onset stimulant use therapy had increased cocaine, methamphetamine, and prescription stimulant misuse disorders or use disorders. And so really this is, we got to rethink the implications on screening in these age groups based on the data. Right now, the USPTF, the United States Preventative Task Force, who enforces and kind of recommends guidelines on screening, does not recommend screening for people under the age of 18. I would argue that as we look at these data, we need to maybe rethink that, but in a very kind of user-friendly way, because none of our primary care doctors have any bandwidth to ask one more screening question. And so it's got to be efficient. We also really wanted to look at, are all stimulant use disorders, are they equal or are they not equal? And I don't think this comes as any surprise to any of the clinicians on this meeting that they are not equal. So using 2015 to 2019 NESDA data, looking at 282,000 respondents with past year use pattern, what this study highlights is that illicit methamphetamine and polystimulant use disorders have significantly higher prevalence rates and adjusted odds ratios for having a severe stimulant use disorder as opposed to a mild or moderate. This points to the fact that really clinically methamphetamine and polystimulant use disorders where people are using multiple forms, Adderall, crack cocaine, methamphetamine, really need a higher level of services and wraparound care to help people get well. So to summarize, ADHD is a risk factor for not only cigarette smoking, but for substance use disorder. Teenagers and young adults with ADHD really should be asked about their potential problems. It should be considered in adolescents and adults who smoke, vape, or have a substance use disorder. About 1 in 10 are going to have it. Treating ADHD helps protect against the onset of not only substance use disorders, but cigarette smoking, and it normalizes car accidents. So if you treat kids with ADHD early, their rate of having car accidents looks like population controls as opposed to significantly higher. It also decreases substance use related criminality. So strategies exist for management of substance use disorders within the context of ADHD. It is a higher risk group. It requires some mitigation strategies to help your brain help you, which is what I always tell people. We want to set you up so that the person continues to get well and that the substance use disorder doesn't flourish. So from a 30,000 foot view, if I had only one question to ask a patient, right, to really help me assess risk, that question would be, in the most non-judgmental way. Hey, have you ever used stimulants that you might have borrowed from someone else, or used your own prescription that kind of was left over, or like used them differently than was prescribed because you felt like they weren't helping enough? That one question, I think, is the marker to when we need a deeper dive to look into the substance use disorder component of it. I just want to throw out multiple thanks to all of the team members and all of the institutions that have worked on a lot of this work. I threw in some supplemental figures because I think they can be really helpful for people to really understand and conceptualize ADHD. This is a great figure from a group in Brazil about the neurobiology and kind of genetics and the areas of the brain. And then this is really how complicated ADHD is and all of the neurotransmitters and kind of what they do, right? And one of the things clinically we see a lot is combination therapy with a non-stimulant and stimulant often is very helpful to decrease the amount of stimulants needed so people aren't having as many of the side effects. But we also have to be wary, right, of some of the side effects that do occur because we put people at risk for higher rates of serotonin syndrome, for if, they have a bipolar predisposition, for manic episodes. And certainly stimulants are really different than medications like buprenorphine because they can put people into a psychotic state, and the brain really needs a lot of time to heal from psychosis. The nice thing about buprenorphine for OUD is we have this ceiling effect that's protective. Kind of haven't quite yet found that in the stimulant realm. So hopefully, I know that was a really fast run through on ADHD and substance use disorders. There are so many things we can pull in from the Mosaic and from different data sources, which is what we've tried to do. I think if there's one message I can send to everyone is, if somebody has ADHD, especially if you have somebody before 7th grade and they're willing to get treatment and they want treatment, treat early. Teach those kids that this is how you handle a controlled substance. Don't leave them sitting out. And so those behaviors as examples are really important. And then also remember that when we're looking at our substance use disorder populations, that 20% at least are going to have ADHD, and that evaluation is really important. What I tell people when they come in with a substance use disorder and they're concerned that they have ADHD is, we're going to work on this together, but it's never a quick process, right? And it's not a quick process because I often need collateral from people who knew them in childhood so that we can have the risk to benefit conversation about starting stimulants in a non-stigmatizing way, but also put some guide rails medically around it for those patients. So, I think biological markers are really important. Our endocrinologists don't just give insulin to people based on how they feel, right? You check the A1C, the glucose, the blood pressure. And in complex substance use disorders, if you're layering in stimulants, I think it's important to also understand our biological markers as a feedback tool for the patients. And I've never had anyone who hasn't been receptive to that when we're really doing this work in a partnership. So hopefully, this is a helpful quick overview. Love to take any questions or thoughts or experience from everyone else.
Thank you so much, Vita, for that valuable information. It was such a valuable presentation. Before we start with questions, please notice the continuing education credit information should be popping up on your screen. You can scan the QR code by using the camera option on your phone, or click on the links below the QR codes to access information about obtaining your credits. This will also be emailed to all attendees after the webinar. So we do have some questions. I'll go ahead and read them to you, Vita. First one is, what about someone who's a heroin fentanyl addict claiming to have ADHD who's schizophrenic with multiple episodes over 2 years?
Yeah,
Completely,
yeah,
yeah,
right. So on that clinical scenario, right, I've had a couple of these patients with so many severe comorbidities, right? And to me, it really is about how do you manage the thing that's most impairing, right? So oftentimes if we can get them on buprenorphine and stabilize the OUD, and then if truly the schizophrenia is well managed, then we can think about, in that case, I'll often start non-stimulants early, like an Intuniv or a clonidine. Clonidine patch works great in ADHD because you only have to change it once a week. And we go very slowly. I think a better example is the people with bipolar 1 who have had multiple manic and psychotic episodes with OUD and a stimulant use disorder. And really the way that I've managed a lot of those people is we decide together, right? So if the goal is the ADHD is so impairing, then we look at the biomarkers, like is your Depakote level okay? And if that's okay, then is the stimulant level okay? Because understanding the stimulant level also helps understand whether the stimulant use disorder is going up or down. And am I usually giving long-acting Ritalin so I can differentiate that from, say, a cocaine use disorder on biomarkers? And it's about explaining that to the patient, never in a stigmatizing way, and understanding that it's progress, not perfection. And so, if the stimulant levels are 50,000, 80,000 all the time, well, it's probably not working. And I wouldn't necessarily start a stimulant right away. People who have had a psychotic episode, their cognitive impairment is pretty profound for many months. And so I don't want to injure that more by putting them on a stimulant because I frankly don't know if it's the ADHD or the psychosis. And so buying some time and treating with non-stimulants in that setting is often, I think, clinically really prudent.
thank you. Next question, for an addictionist who is dealing with someone with stimulant use disorder with a past history of ADHD who requests stimulants, what is the best course? Refer to psychiatry?
It depends on your comfort level, right? And so, the way it's really up to, I have lots of addiction medicine docs who are very comfortable with ADHD, but an ADHD evaluation really takes a long time. So let me give you an example. I have a healthcare professional who's doing really well, is 4 or 5 years into remission from a polysubstance use disorder, believes that they have ADHD, has symptoms. And when we filled out standardized questionnaires like the ASRS, yep, when we did the DSM criteria, yep, it was all of that lined up. But when I called the two collateral people who truly love this patient, I called them a mother and a sister, there are no symptoms from childhood. And so now this becomes a conversation of, do we want to do a test of variable attention? Do we want to employ some neuropsych testing? Because starting stimulants in this individual carries some serious risk. And how do we do this together in because there's a lot to lose here. And most people are pretty comfortable with understanding that. In a fair amount of very high functioning healthcare professionals who we've gone through this workup with over a month, there's a fair amount of overlap with low needs autism. So, stimulants don't help autism, and other things help autism if it's a low needs autism. And with neurodivergence kind of being expanded, it's really helpful to know that. The other thing is if there is an overlay of significant trauma and the person has not done trauma work, stimulants can be very activating and triggering. And so those conversations really need to be looked at. Do they have availability to do like cognitive processing therapy, or right, which we know drops trauma symptoms by about 50% if you get through the first 8 modules, right? And maybe we do that first and then we reassess all our ADHD tools. And so it's a lot of moving parts. It's a jungle gym, not a ladder in these evaluations.
Thank you. Next question. Do you think there is an approach to substance use disorder that can be looked at in a holistic point of view?
I hope so, right? I hope that's what we do every day. Um, so when I think holistic, right, I think about, right, like we all know that the basic, the best medications are sleep, food, shelter, safety, right? Like if you're really thinking about holistic, and then really when I think about substance use disorders, it's about a partnership. It's about sitting on the same side with the patient. It's about helping them understand what are depression questionnaires, what are anxiety questionnaires, why do we use these, how often, and then really just pulling all the data and laying all the cards out on the table and seeing which cards we want to move together. Holistic approaches to healthcare or to substance use disorder, there is a medical component to it as well, right? So the medical component is, do I think from a safety efficacy profile, if you're open to either methadone or Suboxone for MOUD, is there one that I would prefer or recommend medically? So I have an elderly lady right now who's in the hospital, um, who the methadone is prolonging, giving her a heart rhythm problem, and she had stacking. So by the fifth day of dosing, she was completely snowed, and it offers no protection for her from a fentanyl overdose, right? So we just had a conversation about that, and we're going to move over to Suboxone. And even though opioids aren't her kind of primary substance, um, really it's a stimulant use disorder, right? We know that stimulants, illicit stimulants, are laced with fentanyl. So we just had a really great conversation about why we want to help protect you from overdose and how these choices differ. And so, right, that's the guidance of the medical part. It's kind of like if you walk in to get cancer treatment, right? The oncologist doesn't just line up the chemotherapies and go pick, right? They go, ooh, this one's much better. Ooh, you have bad heart function. I'm not going to use that one. Ooh, this one is going to give you a bad survival and probably kill you. Let's just get that one, right? Like, and so I think that's why it's got to be a team.
Thanks so much. Next question. Patient is 41 and mostly psychotic for past 2 years, suspected claiming ADHD to replicate the high.
I wish I had more information on that, right? So, the things I would really want to know are what are family history? What are the stimulant levels? Has there been any trajectory of following them? What does the family say about when this started, right? Is there, family history of bipolar, right? Like that it's hard to sort out. That one just based on that one sentence. I'm sorry. Yeah.
Thank you. Next one. I have heard some people recommending Vyvanse for ADHD in people with substance use disorder. What are your thoughts?
Yeah, so this is the question of using stimulants for a stimulant use disorder without ADHD, I think. And my thoughts on this are mixed. Um, I, you know, I have done it a couple times. It's been helpful. It is completely off label. There are no FDA recommended medications for using a stimulant to treat a stimulant use disorder. At Immersa, there are many proponents of doing this pretty routinely. I have not seen enough data to show that this works. You know, I think for me, the Harvard group, Tim Willen's group, did a trial looking at using stimulants for withdrawal in the hospital and high dose vitamin C, because acidification can make that withdrawal kind of get better. The data was pretty positive, but it was a super tiny cohort, maybe 30, 40 patients. So I don't know. I think more to be revealed. I think stimulants are really killing people. I think we got to do some work in this space. I think all of this space is contaminated, right, with fentanyl, or the majority of the supply, whether it's press pills or, cocaine or crack cocaine or meth. And so, I worry about these patients. I don't have a good answer. If I did, I'd tell you.
Thank you. Next question, what biological markers do you order?
Mhm. It depends on the disease and it depends on the lab you have. So for an alcohol use disorder, we often will check it's kind of three things, right? So a PEth, a phosphatidylethanol, is a blood marker. Nothing will increase or decrease that. Only a full body transfusion or a massive transfusion will decrease that number because it's on the red blood cells. It's really a marker of alcohol intake that not only tells me about amount, it tells me kind of there's a degradation coefficient. So I'll often look at that with the patient. It tells me about 4 weeks of alcohol use. An ETG, a urine ETG, tells me about 48 to 72 hours. And then a blood alcohol or a breathalyzer, if somebody is coming in and I'm trying to sort out which substance is doing what, we'll also get a breathalyzer. For bigger, kind of sweeps, a UDS, a urine drug screen, is a screening exam only. So, I have consults for people that are concerned about amphetamine use. While the patient was on Zoloft, you didn't check a confirmatory test. So every urine drug screen really needs a confirmatory test if there's a high enough suspicion, or for confirmation, which is either a gas chromatography, mass spectroscopy, or liquid chromatography, mass spectroscopy, so LCMS or GCMS. And oftentimes, I will also ask for people, like in a complicated case where the patient can't talk to me, to look for things like kratom or phenibut, because we're seeing a lot of polysubstances, and those types of withdrawal are handled a little bit differently. For bad kratom use disorders, we often use Suboxone. For phenibut disorders, I'm often treating them with baclofen, or, so I really just want to know biologically what I'm dealing with, because the medications for the withdrawal are different. I will also often check for levels of things. So if I'm looking at a cannabis use disorder, I really want to know their THC content to their creatinine. And then also with the patient, right? Like if that's what they want to work on, like let's look at your levels. And as they're going either down or up, and depression is going down or up, we can kind of decide together, like, are you comfortable with that? Pros and cons of edibles versus flower versus vapes versus how it interacts with mental health. So I think those conversations are really valuable.
Thank you. Next question, if a person is diagnosed with ADHD, will they have to use stimulants for the rest of their life?
That's a great question. Of adolescents, okay, when you move from childhood into adolescence, a third will come off their meds, a third will still need meds, and a third will get a decrease in meds. So that's kind of the rule, and everybody's different. And I think we've gotten better with medications, right? So there's meds like Midasis, right, which is a biphasic Adderall XR that really helps people, because one of the problems is metabolism is so different. So somebody may do well on Vyvanse from their morning dose to their noon dose, and they need that second dose. But split dosing can get complicated in people. It's really complicated for kids because they have to go to the office and get the second dose. There's Asteris, which is also a biphasic medication. And then there's a newer medication of a long-acting Ritalin called Jornay, where people take it at night. And so I really think understanding those medications, clonidine patches, is really important. I think where we're all frustrated is that insurance and what they pay for changes every year. So in January, all of a sudden, they won't pay for the medication that you've been stable on. And that's really frustrating because people just can't afford to pay for these medications. And some of them, even when the generics are approved, like Concerta's generic, aside from one manufacturer, really doesn't work as well. And so then there's all these pre-auth problems, and these are the burdens, right? Not just for healthcare, but more importantly for the patient and not being able to get their medications.
Thank you. Next question. Does treating a patient with ADHD with stimulants ultimately decrease the risk of development of substance use disorder in the future?
Yep. So that's the data that if you treat them 7th grade or before, and the longer you treat them, so early and long duration treatment makes them look like population controls. When you start treatment in high school or after, you're increasing the risk of a substance use disorder. It doesn't mean you don't treat, right? There's just too many things that go into this chili, right? Like it's like trying to take apart a cooked chili. But it means that you have that conversation and the risk to benefit analysis and what would work best to kind of keep you safe within those auspices.
Thank you.
And I just want to point out that one of my co-investigators is also on. So if you have detailed researchy questions about methods or anything, Sean is on as well.
Okay, thank you. Next question. Some individuals who contact my team with long-term methamphetamine use believe if they can be prescribed a stimulant for their ADHD, it would help manage their substance use disorder. It sounds like that is not the case, correct?
No, right? So if they truly have ADHD, right, in some cases, treating the ADHD will help the stimulant use disorder, right? But that's where you really have to do your due diligence. And that's where you have to have a relationship. And just throwing stimulants at somebody, it is not appropriate medical care, right? It's really about assessment, relationship, and what's that going to look like. And oftentimes piling on stimulants, if there's a bad meth use disorder where they're not sleeping, is not going to help at all. And so we start with non-stimulants to get a little more regulation and sleep, a little bit of Seroquel, a little bit of Remeron, the medications that are useful have some use data in the stimulant use disorder guidelines, and then kind of figure it out from there.
Thank you. Next question. Regarding adult ADHD diagnosis, if a child is diagnosed, should the parents be offered testing? This may improve their lives as they likely have been struggling per your discussion.
Yeah, so I would say that's a question to the parent, right? Like, so DSM diagnosis, do you have 2 or more areas where it's struggling? And then if, is it a clinical evaluation that you don't need collateral in because the parent doesn't have a substance use disorder? And that's between them and their doctor, right? Like if I'm the kid's doctor, that is not my purview as the adult's doctor, right? If there's family members, then they need separate evaluations without a conflict of interest.
Thank you. Next question. Where can I refer someone in recovery from opioid use disorder and stimulant use disorder over 5 years in remission who wants to be evaluated for ADHD in Michigan?
Yeah, so really theoretically, any psychiatrist, if we do those evaluations. I think the hardest thing is bandwidth, right? And so in people with addiction psychiatry expertise, there's just not a lot of people. And we're happy to see someone at UMass. Who else? I think I would always, if I need to think about that a little. It's such a complicated question. I'm sorry. The reason I'm stuck is like, well, it's insurance based. Well, it's this based. Well, right. Like, and so I can't just grossly answer that, but I would say either a psychiatrist with an addiction medicine background or an addiction psychiatrist is often the best bet for that kind of an evaluation, because that's where really you got to go slow to go fast, to have these risk to benefit conversations, to decide when some kind of neuropsych testing might be helpful or not. And it's really a very measured, slow evaluation, not a, oh, sounds like it, here's some Vyvanse, because you got a lot to lose there.
Thank you. This individual has two questions. One, I would appreciate your thoughts about neuropsychological evaluations for ADD in adults / diagnostic accuracy, seeing a close to 100% diagnosis for adults referred with inattention concerns, including patients that have denied childhood difficulties.
Yeah. So I think neuropsych testing is an adjunct. I think you cannot surpass collateral. And I think the most valuable component of neuropsych testing is the computerized attention part. It will help make the diagnosis in complex situations. It'll also sometimes help rule it out, but I would never purely rely on neuropsych testing in a complex case. It would be like saying, I'm going to change out somebody's heart valve based on an EKG. You know what I mean? It's like a component, but I need a lot more information.
Thank you. Second part of the question, I worry about long-term risks of stimulant use and its risk for subsequent substance use disorder development, as you have data on older adolescents. Is there data on adult age at diagnosis and subsequent substance use disorder risk?
Yeah, so we're actually looking at some of that right now, but at least in young adults, that risk kind of carries through, like, 25-ish, but more to come. So please hold on that and I'll have a better answer. Sean, if you want to jump in and comment on that, I think this may be more your wheelhouse.
I think it's the right Sean. I just gave somebody permission to talk. So if you're there, Sean, go for it.
Hi there, it's Sean. I'm jumping in here. Yeah, it is a great question, and young adults uh, are at risk if they're not treated with ADHD, and we're seeing that that risk is actually when they do start as young adults, they do still have an increased risk, likely because they have a history of using substances. But if they go to someone who knows how to work with ADHD and substance use disorder, uh, at least our preliminary findings are that their outcomes are much better than if they're trying to manage that on their own. So I hope that answers your question. And as the other Dr. McCabe said, more to come because we are studying this in adults right now.
Thank you, Sean. I think we might have time for one more. I've had several clients in therapy with stimulant use disorder who were previously prescribed stimulants but are no longer able to get those medications due to their substance use disorder. They are now utterly hopeless in their recovery and say they are unable to function without medication. How would you approach these situations?
Same way I would any patient, right? And so it's all about diagnosis, accuracy, and then providing the treatment they need, right? And partnership. And to me, having a substance use disorder with ADHD does not mean you can't get stimulants, but it often means I'm not going to give IR stimulants because the risk is much higher. It often means that if there was a really significant Adderall use disorder, I may want to use a Ritalin just so that it's easier for us to parse out how we're treating the ADHD. And then really regular evaluations of how the ADHD is doing, right? A Connors test, using questionnaires at every visit and understanding how the medication's being taken, right? And so, people like, I have a child with terrible ADHD, and it is so hard for him some days just to do like the regular thing at the regular time. That's not a weakness of his, it's just the way his brain is wired, right? So setting him up to take the medication at the same time every day really helps him to stay regular, doesn't disrupt his sleep, and all the things that are really important. And so working with an adult patient on those behavioral changes in addition to medication, you have to have that engagement. And it's really, it's all about engagement. And then giving people the medications that are clinically indicated.
Thank you so much, Vita. This has been such an informative presentation. Thank you for taking all the questions, and thank you everyone for submitting questions. This is the end of the webinar, and we wish you a good day.